Stop scrolling. A child with sodium 118 can go into seizures anytime. But the real question is, do you treat the number or the cause? Hyponatremia is not just low sodium, it is excess water entering brain cells, causing cerebral edema. First rule, never jump to treatment. Always ask one question. What is the plasma osmolality? If osmolality is normal or high, this is not true hyponatremia. Think pseudohyponatremia or hyperglycemia. If osmolality is low, you are dealing with true hypotonic hyponatremia. Now the real game begins. Next step, look at the patient, not the report. Is the child overloaded, normal, or dehydrated? If the child is edematous, think hypervolemic hyponatremia, heart failure, nephrotic syndrome, liver disease. Now check urine sodium. This is where most people fail in exams. If urine sodium is low, body is trying to hold sodium. If high, kidneys have failed. If the child is dehydrated, think hypovolemic hyponatremia, diarrhea, vomiting, burns. If urine sodium is low, loss is outside kidney. If high, kidneys are wasting sodium. Renal losses include diuretics, renal tubular acidosis, mineralocorticoid deficiency. If the child looks normal but sodium is low, think euvolemic hyponatremia. The most important cause here is SIADH. Excess ADH causes water retention, sodium dilution. Also think hypothyroidism, adrenal insufficiency, and water intoxication. Now the most important point, symptoms decide treatment, not sodium level alone. If seizures, give 3% saline immediately, don't wait for reports. Correct slowly, otherwise you can cause osmotic demyelination, which is irreversible. So remember this flow: osmolality, volume status, urine sodium. Diagnosis becomes crystal clear. If this made hyponatremia simple, follow 5-Minute Pediatrics. Because here, we don't just teach, we make concepts stick for life.